going to go through some ideas about mold and also environmental medicine at the beginning, just to give you a set the scene about what can happen. And we'll see how we go with this. So just to set the scene, the environment, which is the orange bit on those big pie charts, it has a huge impact on our health and in terms of the burden of disease. So we know that, that's the WHO. And we know that it comes from many different areas of our environment, from climate change right through to air pollution. There are a variety of ways that we are affected all the time by these things, even if we're not sure of them, in terms they can be at a distance. There are a whole raft of different toxins, and I'm not going to talk about all these, you'll be pleased to know, but I will come back to mold in a moment. Again, just a nice way of looking at it in terms of those health effects, whether it's from industrial sources or other things that are nearer to home. And really, toxins and chronic disease are the kind of elephant in the room, because often we can't see them, feel them, smell them, but they are there. And there is some evidence that they may be behind some of these things, including obesity, diabetes, depression, etc., as part of the triggering of those conditions. And certainly the whole concept of chronic disease, which we deal with as part of integrated medicine. Like this one, this is Mark Cohen, has made these slides up, so I thank him for these. Basically, persistent organic pollutants are everywhere, and unfortunately the home is a good source of them. But they're affecting not just us, but the animals around us. And the breast milk in the States, every few years, the EPA, the Environmental Protection Agency, does a study to see what pollutants are out there. It's hundreds of them that they look at. And there are some always in breast milk, large numbers in breast milk. And as far as I recall on the last one, every American had some jet fuel and some of the very popular herbicides, including glyphosate. We really don't know. That's the other part about it. As I said, we don't necessarily see these things. We know that in our environment, there's a huge number that are used, but in fact, the great majority have never been researched for toxicity, the really great majority. And also, we have no idea once you start combining them. So we tend to be caught up in a kind of mix of potential pollutants. And this is one of the problems that we're finding, because they're really not very well tested. I won't go through. This was just showing the concept of a small amount can have one effect and a large amount can have another effect, the U-shaped curve. And a lot of pollutants do this. They're not a linear effect often. They're often a U-shaped effect. And this was just showing that each of these two very similar mice were given completely different doses of DES, which is a stilbestrol compound, and diethylstilbestrol. And the one on, let me just get, that was given a lot of it was scrawny, and the one was given a minute amount became obese. So that's, whereas the normal is in between the two. And we know that it tends to happen, Malena talked about the fact that in utero is important for the gut. We also know that a huge amount of toxins can be transferred over during in utero. So this brings me on to mold, which is another form of pollutant that we're starting to get a much better idea that it has effects on human health, and for some people it can affect their chronic health. So I'll go through this. Mold is a normal plant. We exist with it. It's a huge part of what's out there in nature. And some are really useful ones. Some break down stuff, get rid of it. And some produce wonderful things like fermented cheeses and alcohol. So they do some really wonderful things. In history, there's various evidence of it. One of the first house plagues was mentioned in the Bible, apparently, and then there's been various forms of poisoning out there. And this is the so-called St. Anthony's fire, reported originally around, I think, the 16th century, but there was another version of this in the 1950s where ergot poisoning, which ergot can be metabolized into forms of ergotamine and lysergic acid, which is LSD. So it can have a whole raft of different effects when people ate usually bread or other similar substances made from affected crops. And again, there's some idea that the witch hunts in the 17th century may have related to this. Mold needs water to survive, and so that's a really important thing. Obviously, spores can exist without it, but the actual mold mycelia, the plant itself, needs water, and it will typically begin quite quickly after there's water in any area. So if it's not checked, it will tend to want to keep growing, and so stopping those water incursions when it comes to buildings is really, really important. And in many ways, it's another elephant in the room, quite like this one, because sometimes we have no idea there, and perhaps the majority of times in houses. So here we go. Various causes of it, from obvious ones like roofs and plumbing, right through to just condensation due to temperature. What molds aren't is the blob. That was a Steve McQueen film back in the 50s, and again it was another version in the 70s. It's much more like this, where it can get into structures either in the ceiling, walls, floors, and set up shop and be there even behind paint, under carpets, etc. These are some very gross examples, but quite often they're smaller. Here it's in the roof, in the eaves, and people don't necessarily look in their roofs, and under carpets. So definitely it tends to be around. It can also be in ductwork. That's in various forms of ducting in houses and buildings. So that's fine, but how do we find out about it? Do we test? How can we do that? And this is part of this is from Nicole Bilsma, who's an environmental biologist. She has written a very good book around these things. I'll bring it up at the end. But really, the first step is not normally to evaluate where the mold is. It's recognizing, one, that there is a problem, because tests to actually grow mold and recognize how much is there and whether it's abnormal or not can be quite difficult. There are some standards, however, for various types of molds, and the problem is actually getting a good sample, whether you're plating it out from part of the furniture or the walls or the floor, or whether you're using a special device like this, which is a way of sucking in air at a set rate with plates inside the top part, and that over a set period of time, and that then gives you an idea of what molds may be in the air. Mold remediation, that's a very big subject, and I'm not going to go into it to any degree, because first of all, the obvious thing is to try and prevent any water coming into a building. When it comes to trying to clean areas that have been affected, it is difficult, and often anything that's at all porous, it can be almost impossible to fully clean it. And the only way around that is actually to remove those materials, whether it's flooring, whether it's jib. Molds will live perfectly well in jib if it's moist. Soap and water for non-porous surfaces like windows is simple. You don't have to bleach them, you just have to clean them. One of these interesting studies here, it's a New Zealand study, and it showed that the high humidity, particularly in wintertime, was the perfect environment to get mold. And when they actually looked at it, they found there was a huge percentage of cold bedrooms had mold growing. What are the health effects then? So how do they affect us? Well, there are various possibilities. One of the ones obviously is allergic reaction, as in asthma, etc. There is an unusual thing where you get a pneumonitis. That's not very often. Some people, it's part of an ongoing secondary process, particularly people with emphysema and other things like that. There are various chemicals that can be affected in the actual dust, which can bring about strange symptoms. Glucans, which are one of the protein carbohydrate combinations, can do that. And the mycotoxins themselves, which I'll actually be talking more about. Allergic reactions, very quickly, I've kind of mentioned the obvious things that you get with atopy, and it tends to be much more around the dust part related to those moles. It affects quite a bit of the population, up to 5%. Infection, yes, more in the immunocompromised person, and other than the obvious things like athlete's foot, which we don't normally worry too much about. So back again to mycotoxins. There are some very simple things. There are irritant type mycotoxins, which we're not so bothered about. They tend not to be that volatile. However, they can be breathed in, and what they do make is they often make volatile organic compounds, and these are part of the things that we're concerned about, and to some extent they can be combined with other forms of VOCs that can be within the house as well. And we mentioned about the idea of the iceberg, and this is the tilt idea of how people lose tolerance to things. The idea that you see the obvious iceberg, which you can run into, but what tends to happen is that the lower bit, the susceptible person, gets some initiation process going on. And if that keeps going, or it's severe enough, they will get a loss of tolerance to it. And then they become sensitized. And then finally, they're very obviously reacting. So these stages often go on pretty undetected. But by the time, obviously, you get to symptoms, it's a matter of finding out where did it come from. These are various things that we know can cause that kind of tilt phenomenon, toxicant-induced loss of tolerance, and certainly the VOCs and molds can be part of that. I won't go into this too much, but there are various main mold toxins. I think we heard a little bit about them earlier on in Tracy's talk. And we know that certain of them will cause certain types of reaction, whether they're more about carcinogenicity or doing effects to various organs. Also, as I mentioned, there can be a kind of, they put here biochemical stew, a mix of different fungi, bacteria, and other organisms, along with other chemical related particles. And what the sort of water damage building is, it's often a huge mix of all of these. There's something that we're now starting to recognize. It's still a little controversial, but it's becoming more widely accepted. The idea of something called chronic inflammatory response syndrome, or CIRS. And particularly in related to molds, but probably in many other conditions where you get a multi-system, multi-symptom illness. We see this a lot in many types of illness like chronic fatigue, fibromyalgia, etc. Where they've, in this situation, they've been exposed to various toxins, and right now we're looking at molds. There are various biomarkers in this situation that may be useful, and that the illness, if we're on target, will respond to specific therapies. So that's the usefulness in terms of CIRS related to mold. There's also some evidence that this process is partly genetic. And what they've looked at is that a proportion of the population can't make antibodies to mold antigens, and that allows a persistent inflammation to continue. So this is one hypothesis, and they've looked at various gene combinations and HLA ones, and some here are listed that seem to be quite probable markers of that. Symptoms of CIRS, well, I'm afraid they're multiple because it's a multi-organ process. So depending on which organ's affected, and I've listed some of these, a lot of these come from Shoemaker's site. I'll show you what that is in a while. He's an American doctor that has spent the last 15, 20 years researching and writing on this area. So gut-related ones, skin, various endocrine possibilities, and so on. Brain fog and musculoskeletal, etc. What he found in his way of looking at it is he's boxed these things together in certain boxes of symptoms. And this is to get an idea that if you have 8 lots of these boxes affected, then you're very likely in his research to have a biotoxin related illness. This is to make it a little bit more complicated. Again, Michael Shoemaker's graph or diagram, where a lot of it he relates to MSH, melanocyte stimulating hormone, that you have this effect coming in, a biotoxin pathway going around affecting various different mechanisms and structures in the body through various processes. So quite complex. And I suspect that's one of the reasons it's been hard to really study, because I think it is complex. And he has this pyramid of therapy, if you like, or how to go about trying to help people, starting from the base and working up if it's needed. So there's a phase 1, as you can see, 1 to 5, phase 2, 6 to 10, and the final phases if needed. And I'm not going to go into these to any great extent, but he has a good website and he's written a book, so you can actually go along and have a look at these things. In terms of treating patients, I'll come on to some case histories and give you an idea, certainly from my perspective, how you can use some of them. And most often you don't need all of them, but I will mention some. So obviously removing someone from exposure of mold is the very, very first thing to do. The second thing, which is probably a really good test one, and I'll come back to, is using the resin binder cholestyramine or cholestid, because what it does is it prevents a particular pathway of toxins from the liver through the bile and being resorbed back up again, the enterohepatic pathway. So here's a patient I thought we could start with and get some ideas from. I've had quite a number of patients now who seem to fulfill the CIRS protocol and have responded well. So a 68-year-old who's very obese, unfortunately, has mild diabetes and treated hypothyroidism. She started getting a number of different sets of symptoms. I've listed them there. Very common for some of the patients we see, which have a mixture of chronic fatigue, fibromyalgia, and so forth. All the usual tests, other than she's got mild diabetes, were normal. And she's been through all the usual things that we do to try and help people, including looking at sleep apnea. And however, I thought at one point, we've got it, we'll put her on CPAP, but I'm afraid it made very little difference. I then went into what are the environmental factors for her, and it turns out that she's living in a damp council house, and she has relatively low income, but we thought the only way we can help her is to actually see if the council will make changes. And this is part a political thing, because she'd been living in this flat, she liked it, but there was definite, very visible mold on walls, cupboards, etc. And whenever she asked the council to do something about it, they would either paint over, go in with a brush, sweep it off momentarily, and made no major changes. So I decided, we decided we'll check out her mycotoxins. And here we are, here's a set of her ones. And you can see she's managed to get 3 of them together. And these are enough to show, first of all, she has a very definite mycotoxin-related problem, or at least she has mycotoxins. And we have since thankfully used this with the council and several letters. And she's finally been moved out to a dry accommodation and starting to make some improvements gradually. So that's the remediation, if you like. This is a lovely young woman, 39-year-old, who is a mother of 4. She had very little in the past, family history with not a lot there, although she had a daughter who died of genetic abnormalities. As I said, 4 children, 2 of whom are twins, and basically living a pretty good life. However, even though she'd been in a present house for 10 years, which had been a new build, she started to find mold in various cupboards and other places. Now, why was that important? It was because she had these set of symptoms. And this is taken from her own notes. She had a raft of symptoms that had been coming on over 2 to 3 years and getting more and more severe. And again, I think that's that tilt thing I mentioned where the tolerance had started to disappear over time. Her ability to handle any biotoxins was disappearing, and she was coming up with more and more symptoms as time went by. And she got hold of me at that point, and she really sounded very, very unwell. She lived at quite a distance from where I am. And I said, well, look, the first thing you can do if this could be a mold problem is actually leave your house for a while, because they hadn't had any long holidays away. They had no idea what the difference would be. And that can be part of the story, of course, is asking people if they go on a holiday of 2 or more weeks, does it make a change to their symptoms? Although there are some limitations to that in terms of you can have mold in clothes and elsewhere. We did the usual investigations, not a lot of abnormalities, minor things there, low zinc, lowish vitamin D, etc. So now what? Well, I did check the mycotoxins. She had a very high ochratoxin A level, and that gave me ideas that we are dealing with a degree of mold. I then went on to do another set of testing, which I haven't mentioned so far, but it's part of the Schumacher's protocol. And this is where we looked at several different factors that can lead to CIRS. So people often with CIRS have high complement 3A and 4A. She had massive levels. Metallopeptidases can be high, and so forth. And they tend to have low MSH or variable levels of MSH, it depends. So she fulfilled it in 2 ways, in a sense. One, there was definitely mold mycotoxin. And secondly, she was showing CIRS type symptoms. Just to remind you again, some of those things we were talking about there, the complement, etc., part of his phase 2. Just to let you know the protocol, I'm putting that in more for completion. I'm not going to go over it right now, and I put down at the bottom one of the websites you can go to look at that. So some of the reasons he's learned to do these is because they are changed to various amounts, and there are various ways of trying to improve upon them. What happened for her? Well, as I mentioned, she moved house. First of all, went into, unfortunately, a rental property, and it was within 2 weeks she realized there was mold throughout that property, and they left, and then finally got into a house that is dry. We started her on cholestyramine, and in fact, I think it was Cholestid in this case, and she very quickly started to feel better within days. Not completely better, but some of the symptoms went away very quickly. And that can be a telltale sign if that happens. I better keep moving. We did various supportive things, which we would normally do in an integrated way with diet and nutrients. I also provided with low-dose naltrexone N-acetylcysteine, B12, and actually glutathione, I hadn't put that. All of those started to make her feel a whole lot better early on. How did she do? She made remarkably good progress, I'm glad to say. And since then, in the last year, this was 2 or 3 years ago, I saw her. She's had a planned pregnancy with a good outcome, so she's managed that fine. And her own family has felt a lot more healthier. And when I asked her what had been going on, originally in the notes, I took this down. Oh yeah, this was her husband. He'd got brain fog, memory, quick to anger, a whole lot of conditions. The older son had various things going on. The twins, they had their own problems. And finally, the youngest child also. Thankfully, at least according to what she's told me, a lot of these things improved when they swapped houses, went through all the things that we'd talked about. I haven't talked about filters and other things. They did a number of other things as well. And so the whole family, it would seem, had been getting some degree of problem. Liver detox, just to mention it, there are various things we can do there. This is just some basic things for phase 1 and phase 2 liver detox. Sauna can be another way of removing toxins, by the way, generally speaking. So as a take-home message, and I'll be open to questions in a while, really, it's a matter of being aware that our environment can be a very important source of toxins. Mold in damp houses. I haven't mentioned that certain foods may produce molds as well. That's another whole subject in a way. Remediation is very important, although it has to be very good remediation, because I've met a lot of people now that have done partial remediation and not done so well. Consider the possibility of CIRS, particularly when you've got these multiple complexes of symptoms going on and getting worse and worse. Cholestyramine or cholesterol is a good way of checking out, do they have some fairly rapid improvement in some of the symptoms? That's a good sign. And there are various resources there I've put in there, including Nicole Bilsma's one at the bottom. So thank you very much. That is my quick romp through molds and a little bit of environmental medicine.
Can I just say to all the participants, I'm sorry I haven't met you. I actually went to Christchurch over a week ago because I come from Christchurch, booked into the hotel and then was told I have to come back home. So it's sad that we haven't been able to meet each other, but thank you for being with us. I've appreciated that there are people out there who are listening to us. I just want to talk about the importance of vitamin D in human health. This is, I said in the question time, I look forward to having simple solutions, and vitamin D is a simple solution for some people. It's not for everyone, but a lot of people need it. But sometimes when you give vitamin D to people, you get an amazing result. It's a bit like what happens with celiac disease. That's another simple solution that I always look for. I don't need to tell you about me now. You know who I am. Just a declaration. You'll see on this that my prescribing is 3 times more in vitamin D, this is cholecalciferol, than the average doctor. And in those practices like mine, which are in the more affluent area, which means that the affluent doctors are not prescribing much vitamin D, I'm 6 times as much. So that's just a declaration that I'm biased. I'm totally biased towards vitamin D. Vitamin D deficiency has its beginnings really in the Industrial Revolution, when people went from outdoors to indoors. And this is the first paper that was written on rickets in 1776 by Thomas, which said, you know, we have a real problem. And it took till the 1920s, as you'll see down there, we found out that sunlight would help, and we found out that cod liver oil would be helpful. But it took another 60 years after the 1920s until we worked out what the actual endocrine pathway of vitamin D was. So this is it. Remember that vitamin D is not just a vitamin, it's actually an ancient hormone. It's a corticosteroid, it's actually a bent steroid. We know it's fat soluble. You've already heard today about ultraviolet light on the skin. Just going quickly through the pathway in the dotted lines here. You know about the ultraviolet light. It's made from dihydrocholesterol, and then by heat it's converted into vitamin D3. Just remember though, the conversion from vitamin D3 here into its 25-hydroxy form and 125-hydroxy form takes time. This conversion here from D3 on might take, I think, 3 or 4 days. It's not a rapid conversion. So if you see something acute and you want to load people up with this form, it may take longer than what you think to get to this form. If you look on the left here under D3, this is cholecalciferol, which I prescribe, which doctors prescribe here. Calcifidiol here, this is more easily absorbed, I think. We don't have this here, but I think in some of the COVID trials, they were giving this, and it seemed to be helpful. We'll get onto that later. So I'm just going to quickly talk about the endocrine pathway. I don't want to talk, I mean, when we think of vitamin D deficiency in the endocrine pathway, we think of osteoporosis. So I'm not going to talk about that part of the pathway. So this is a gentleman who I saw for the first, these are my notes as they are. I've just copied them in here. I haven't altered them in any way. 38-year-old Indian male, 83 Ks, came to me on the 5th of August. He was fed up with his own doctor, who he'd seen for a long period of time. 5 years history of digestive problems, bloating, bowel motions. He had constipation to diarrhea. He tried a keto diet because the doctor said, if you want to lose weight, try a keto diet. Actually made him worse. He felt worse. He had acid reflux, was worse with stress. It was worse with dairy, worse with fruit juice. And he had bloating as well. Bread made him worse. He had muscle fatigue. He'd stopped going to the gym because of the bloating in his abdomen. He didn't like lifting weights or putting things above his head. He had a blood ALT. These are ones he brought with me. This is, and I presume the ALT, he probably had a fatty liver. He'd had nose trouble. He'd had a septoplasty. The ENT guys had made him worse, and now he had a collapsing nostril. Not a nice thing at 38. And he had a constant post-nasal drip. So when I examined him on that date, there was not much to find. It was probably a bit bloated, obese in his abdomen, but there was nothing really to find. We talked about food intolerance. He knew about dairy. I wondered about fructose. I always think about gluten. Just a wee thing about gluten, always remember it's 1 in 100. In my practice, we have 8,500 patients. We've only got about 63 patients with celiac disease. So we've got a few more to find, and I'm always looking out for that. His mother had rheumatoid arthritis. His father had lipid problems. We talked about the diabetic connection. I told him to go and get some bloods done, and I referred PC and you'll meet PC soon, the gastroenterologist, because of all this gut problem that had been going on with him. He had muscle fatigue. We talked about inflammation. We talked about vitamin D lack, and I said to him, maybe calcium might help, magnesium might help. But I gave him a script for vitamin D. And I said to him, because he was Indian, and you'll find as we go on what I think about skin color, I said to him, mate, you should take at least 1 capsule a week. This is the result of his vitamin D, which came back the next day. It was 16, and as you'll see here, less than 25 is moderate to severe deficiency. A month later, I received this letter back from the gastroenterologist, and this is the summary paragraph at the top of his letter. Symptoms of abdominal bloating, diarrhea, and exaggerated gastrocolic reflex, recently found to be vitamin D deficient on supplementation. Symptoms have markedly improved with vitamin D supplementation. And Paul Casey writes in the letter, originally he felt he was lactose intolerant, it would get diarrhea and be bloated with any lactose and also have acid reflux. In the last 2 to 3 years, this has become worse with multiple types of food causing bloating and diarrhea. He moved to your practice, had a RAFA blood test, and was found to be vitamin D deficient. He's gone on vitamin D replacement regime, and the bloating has disappeared. The diarrhea has resolved and the acid reflux has also resolved. He no longer has lethargy and is able to do a lot of work on his house and he would normally not be able to do. With the reduction in the bloating, his belt size is reduced. He's slowly introducing foods which would normally trigger diarrhea. The last night he had beef stew, which would normally trigger significant diarrhea. He said he did have some mild diarrhea with that, but it did not last for long. So when you get that response, you think, oh, that was really clever. These people think you're a god, actually, when these sort of things happen. So just a wee thing about vitamin D deficiency and calcium as it relates to the musculoskeletal system and the gastrointestinal system. In my practice, osteomalacia, which is soft bones in adults, is not uncommon. Suggestion, if you see people who have dark skin, press on their sternum or on their tibia. If they're tender, always think that. Rickets, I've had 2 children with rickets, so it's not uncommon. Remember, calcium is the most abundant mineral in the body. Remember, with vitamin D and calcium deficiency, it affects bone. That's obvious, and we know that with osteoporosis, causes pain, causes dental decay. Muscle contractions are affected with aches and cramps. Has an effect on cell membrane conduction and signaling. So paresthesia, tetany, confusion, tiredness, mood, depression, and gut motility, as what happened in this gentleman. So I just want to share some studies now as they relate to problems that I have heard people talk about this last year. I've heard people talk about kids with holes in their teeth. No one ever mentions vitamin D supplementation. So here's a systematic review, meta-analysis that was done in 2013 on 24 controlled trials. Supplemental vitamin D was associated with 47 reduced risk of caries. And if you look at this forest plot here, you'll see this favors here vitamin D. They're all down this side. The only thing is, though, once you get beyond 13, the vitamin D supplementation may not be able to do the same in getting rid of the holes, suggesting that growth and variations in body fat, which we'll come on to later, may influence the effectiveness of the fat-soluble vitamin D in the caries prevention. It's not just holes in the teeth, it's also the development of the jaw and the teeth. So this is a study from 2019 in Holland, where mothers in their second trimester had vitamin D levels done, and then they were watched. There was a control group, and they looked at the ones who had low vitamin D. And what they found was that the ones who had low vitamin D, the low vitamin D accelerated the development stages of the mandibular canine, the first premolar, the second premolar, and the second molar. So these teeth became greater in their expression when they were low in vitamin D. This was seen more in the obese and the malnourished children. And just remember, when you see kids who have got overcrowding and narrow arch, think about vitamin D lack, particularly in pregnancy. This is effective of what's happening within the pregnancy of that child, or in the mother who has the child. So who's at risk of vitamin D deficiency? And this is pretty straightforward stuff. Skin color. For 10 years, I was really enthusiastic about doing vitamin D levels. I spent, I think, $250,000 on vitamin D. I think after I did all this stuff, they closed it down. So now you have to have a good reason for doing it. But you'll see, if I consider about 80 nanomoles per mil to be, which you should be above, that in my practice. So I'm affluent, more European, but we have mixed cultures. Most people, in fact, were under that line. If I break it down further, you'll see that the European are higher, but as you come across, you'll see here going across Maori, Pacific Island, Asian, Chinese, Indian particularly, Middle Eastern particularly, are low. So in my results, just look at the darker blue, the lower area, because that's vitamin D deficiency. So this is in males at the top. You will see that Middle Eastern male is the highest, and then Asian and African would probably be next. But in particular, if you look at the female, you'll see that Indian females and Middle Eastern females are really high. So if I see them, I consider, certainly with Indian ladies, they're nearly all vitamin D deficient. Sunlight exposure, you heard about that today. So I won't go into that. Obviously, it takes longer if the sun has to go through a longer angle as we change into winter. But remember, if your body shadow is shorter than you're probably producing vitamin D in your skin. If it's longer, you're not producing any. So just look at your shadow. If the shadow is longer, you're not producing vitamin D. If it's shorter, you are. So that's a good way of remembering that. And don't forget age. When you look at teens compared with older people, the older people produce half the amount of vitamin D in their skin. Obesity. Those who are obese, again here, produce half the amount of vitamin D in their skin. So all the obese are probably not using their vitamin D very effectively. I thought this was interesting when I came across this study. This is to do with surgical outcomes, where they looked at, this is a study that was done in 2015, where they collected a whole lot together. They looked at 31, and this is of 26 of these studies. Vitamin D lack had bad predictive effects on surgical outcomes. So if you look at the bottom here, hospital-acquired infections, graft failure, cancer, myocardial infarction, low cardiac output syndrome, stroke, ICU and hospital length of stay was longer, and the 1-year mortality after surgery with those who were low in vitamin D was greatly increased. So my plug for you today is, if you're having people who are going to surgery, make sure that they've got adequate vitamin D. I supplement everyone. I think most people, and when you're under surgery, the vitamin D level goes down anyway. So always think surgery, need more vitamin D. Now this study came out last year, or this year. The UK Biobank, no, it was last year. The UK Biobank is just a collection of data, and this was analysed by Chinese and Harvard researchers, and they knew the vitamin D of people before the study started, and they followed them here for 8.9 years. So this is 365,000 plus people they followed for 8.9 years. Now, I'm not great on stats, but I do know that hazard ratios, if you have a hazard ratio of 1, it's more like normal. So when you look at these graphs here, so this is vitamin D concentration down here on the horizontal axis. When you look at this, when it goes down like this means that there's increasing mortality. And in all-cause mortality, this levels off at about 60, and then after that begins to go up towards normal. The same is true for cardiovascular. It goes down to about 60, and then there's a slight increase. And in cancer mortality, it's not quite as far down, it's 45. So this was their conclusion. Mortality levels off at 60 nanomoles for all-cause and cardiovascular deaths, at 45 for cancer deaths. And then if the concentrations were higher, there was improvement in all-cause mortality by 17%, 23% in cardiovascular risk, and 11%. So if you have a low vitamin D level, you're at greater risk of dying. Now, just quickly, I want to talk about this other side of this diagram. So this is the autocrine function of vitamin D. This is where vitamin D, the 25 hydroxy vitamin D here under the liver here, can be taken up directly by cells in the body, and they can convert it into the active form. Remember that vitamin D is a superfamily of nuclear receptors on all cells. It influences up to 2,000 genes. Some cells express 1,25-hydroxy vitamin D3 themselves. And this is particularly important here for the innate immune system, the brain, the breast, and prostate. So I'm just going to talk about relevant things that are happening to us now. I'm not going to talk about this paper. I would encourage you to read Michael Horlick. Michael Horlick's the PhD Harvard professor who in fact found 1,25-hydroxy vitamin D. He was the one who worked out that final pathway. And this is his 2020 overview on how it affects all these things. Good article, download it, have a read of it. This is part of it. So I'm just going to talk now about the effect on the immune system. So vitamin D has an effect to modulate toll-like receptors and the natural killer cells. I've talked to you already about toll-like receptors and natural killer cells when I talked about naltrexone. Vitamin D increases these antimicrobials that are produced in the immune cells, cathelicidin and defensins. It decreases inflammatory cytokines and increases the anti-inflammatory cytokines. It makes things within the cells more tolerable. The T helper cells are actually increased, the CD4 and the ratio. What about the vascular endothelium? Well, vitamin D stabilizes the cells and decreases permeability. I think the most interesting thing here is cholecalciferol, that's what we prescribe, is 100 times more effective at doing this than the actual active form. So in conditions where you wonder what might be happening, I mean, COVID's an example to the endothelium, it might be important. Increases nitric oxide has a protective effect on tissue and inflammation, and also on the renin-angiotensin pathway. This is another thing with COVID. Decreases the angiotensin converting enzyme. And then finally, to do with the innate immune system, has a protective respiratory tract on infections. So I'm just going to quickly go over the respiratory things. Asthma. So this is a published review in 2019 on data that Cochrane took out of 2016 on 7 trials in children and 2 trials in adults. And this was in a duration for 4 to 12 months. And they used varying doses in children. It was about 400, in adults it was between 1,200 and 4,000 units daily. There were no serious adverse effects when they reviewed these trials. They reduced the amount of steroids used. And the vitamin D is likely to reduce both the risk of severe asthma and exacerbation and healthcare use. I think this was an exciting paper when this came out this year in April 2021, because this is the University of Auckland. So at birth, the vitamin D level was actually done on the mothers. And then they were actually watched to see what was happening. They divided them up into the low level group, which had a mean of 46, and the higher group and the match controls here had 61. The ones who had the lower level, the 46, were twice as likely to be admitted to hospital with acute respiratory infection. These 2 papers below are in this main paper from Auckland University, which is interesting. The vitamin D, this is globally, vitamin D deficiency less than 50 is present in 54% of pregnant women and 75% of newborns. Severe vitamin deficiency less than 25 is present in 18% of pregnant women and 29% of newborns. And I think the exciting study that I found was this RCT on vitamin D in pregnancy and infancy, where they gave 2,000 units a day to the mothers, and in infancy they gave 800 units a day to the children for 6 months, and it prevented primary care acute respiratory infections for up to 18 months. So I think that's a really exciting finding. We should be supplementing, particularly in pregnancy, but follow up in childhood. RSV, everyone's heard about RSV. It's running through New Zealand, and no one said anything about vitamin D. But this is a study from Israel that came out this year and to do with acute bronchiolitis. And they found that in children with acute bronchiolitis, they had significantly lower vitamin D levels. And this was more than the children with non-respiratory acute febrile illness. So always think of giving children, particularly in wintertime, vitamin D. Going on to COVID, this is Michael Horlick, who I talked about before, who wrote that paper. This is a retrospective study that came out in September of last year. What he did was he looked at all the states in the US. He knew the vitamin D of 190,000 people, and he watched what happened to these people over a period of time. And you can see that the ones who got had the most severe COVID infections here were the ones at this end. Just a wee thing here, this is in the US units. Where you see 20, multiply that by 2.5 to get our nanomoles per litre. So this is 45. Here, this is up around 150. So low vitamin D certainly seem to make COVID infections more prevalent. A recent study from Israel just looking at vitamin D in people who in fact had COVID infections, those who had the severe disease, in those who had less than 20 nanograms, remember, multiply this by 2.5, so this is 45 nanomoles per litre. There were 48% of those. Those who had it above that were less. Mortality rate in the ones that had it at the 45 level was 25%. The ones who were above were 5%. So vitamin D, if you go into hospital with COVID and you have a low level, you don't seem to do as well. There have been a number of articles that have come across my desk. This one here by a cardiovascular professor saying everyone should be supplemented. This one here saying everyone should take vitamin D to prevent it. And this one here where in fact the public in the UK were actually given vitamin D supplements free for a period. There have been two recent meta-analysis on looking at these trials. This is probably the more favorable one. This is by Indian researchers, and they thought that this is giving vitamin D when the people have come to the hospital for treatment for their COVID. That vitamin D significantly associated with reduced ICU admission and mortality. Vitamin D seemed to reduce the risk of adverse outcomes. They go on to say that the vitamin D supplementation might be associated with improved clinical outcomes, especially when administered after the diagnosis, not before. However, issues regarding the appropriate dose, duration, and mode of administration of vitamin D remain unanswered and need further research. So this came out in June this year. However, Cochrane did another meta-analysis, and this was slightly earlier in May, and they feel on their data, it's probably the same data, so different people read it different ways. Based on the current evidence, we are very uncertain about the effectiveness of vitamin D supplementation for participants with COVID-19. They say there's total inconsistency in the reporting about adverse effects, and obviously to do with the amount that was given and how it was given. Therefore, we cannot draw a conclusion. But my take-home message is this. Vitamin D deficiency is more than osteoporosis. Remember, it has endocrine and autocrine effects. Low vitamin D is associated with increased morbidity, increased mortality in all diseases. Think pregnancy, particularly infancy, think chronic disease, think operations, and obviously dark skin with Indian and Middle Eastern people. I think the vitamin D level should be above 80, maybe higher in acute infection. I think you should consider vitamin D supplementation for all. I think daily is best, but as doctors, we don't have access in our toolkit to be able to do that. So we end up giving 50,000 units. You can give it between 2 and 4 weekly. You have to remind patients to continue taking it. If they don't, they'll forget it. You have to be on this all the time, I think. The only precautions are avoid in people who might get hypercalcemia, sarcoid, Hodgkin's, cancer of the lung, granulomatous TB, and calcium kidney stones. And it's cheap and it's of low toxicity. A simple treatment. Thank you very much.
You just get myself going. Thank you indeed there, Rick. You'll just have to stop your sharing. While you're doing that, there is a question, so you may want to answer that right now. It is vitamin K2 helpful along with vitamin D supplementation?
Well, I think it is in for things like cancer. Is it helpful for things like infection? I'm not sure. But I mean, vitamin K has its own short action as to do with coagulation, but it also has an action long-term to do with preventive properties in bone, cancer and other things. So I think you can use them together in chronic disease.
Yeah, great. Oh, thank you. This is the last presentation. I suspect some people may be pleased by that. It may end up being the most contentious one though. So it's my pleasure now to introduce the COVID presentation. This is actually a shorter version of a much longer one, and I've removed quite a few slides. So I should start off with a few important caveats so that we set the scene. Everyone should, of course, follow the Ministry of Health guidelines. I'm not a virologist or infectious disease doctor. There isn't a lot of very high quality research on COVID-19. There are quite a lot of trials, but many of them not been fully peer reviewed, or they haven't been replicated, and it's a bit of the problem here. I may also extrapolate from other types of studies just to get a sense of what's going on there. And what I'm saying doesn't necessarily represent a recommendation for treatment. And finally, I'm not personally anti-vaccine, in case people are going to start saying that at the beginning. I'm not. So we'll move on, and I'll talk a little bit about vaccination, but not a great deal. So if we start looking about the virus itself, this is a graph which takes us through to a couple of weeks ago of what happened starting at the left, the original virus as far as it's known, and all the different strains and modifications that it's undertaken. And you'll see that the Delta one that we're concerned about now is this set of strains along here, a large number and many different versions of it. And that obviously is causing a great deal of difficulty. I'll also just let you know about, there's one called Lambda here, the orange one, and that's coming along particularly in South America. And it may be even more resistant to some of the treatments than the Delta one. It's looking particularly difficult. So there are various ones that are still coming through, which may cause even greater problems than we have at present. And this is just a similar map showing whereabouts in the world the different amounts are. A very quick mention about the fact that the ordinary flu, which is the red graph in this one, the red line, does normally affect a similar number of people in ICU each year. But obviously what we're concerned about is the death rate from the COVID virus versus normal flu rate. We know about some of these, so I'm going to cover them quite quickly. There are various comorbidities that put people at more risk of serious illness or death. This is interesting. This is the p-scores are how much extra death in a population above the normal background death rate. And so these are various countries. The pink tallest one is the UK, starting back in March last year, where they had a huge increase in death rate. And they had another one again at the beginning of this year. But if you look at all of these different countries, they're right actually down at a very low rate of deaths at the moment. So that's a kind of interesting process. South America may be having a bit of a lag phase there. I'm also putting this one out there because it's just interesting statistics. This is a site, Euromomo, which has been going for many years, and it plots the same thing in terms of death rates amongst all European countries. you can look up each country in Europe and see what their annual death rates are at different times of year. And these are what we call influenza-like illnesses. So things that seem like influenza and people die from them. And what you'll see is every year there is a peak, and some years are worse than others. And this is the likely COVID-2 peaks that we're seeing at the moment. But I just draw your attention, certainly in Europe, the actual excess in death isn't as much as you may have expected in those years. We know that various organs are affected through COVID. MACE is cardiac ones, so the cardiac system is the most commonly affected. And we know that it also affects the brain in quite a proportion of people, in hospitalized people particularly. The ACE2 inhibitor is one of the main problems, and it's still unclear how much is direct injury or through an immune process for some of these. I'm going to mention briefly post-COVID syndrome. Normal viral response goes there and it starts to drop down. In the PCR negative still, but going into post-COVID, we have these different symptom complexes happening over time. The prevalence of long COVID is variable depending on which study you look at and obviously which age group, but in the over 45s, it's certainly quite extensive in some places, and various studies have reported between 13 and 80% going past the sort of 2 months or more of symptoms. What are the symptoms? They are very varied, and all the sorts of symptoms we often see in post-viral diseases anyway. So it's part of that spectrum of possibilities. I put this in here because I find it quite interesting that the concept here that the brain dysfunction, the brain stem, may be a large part of some of those symptoms. We know that because of the ACE2 receptors that the brain stem is particularly affected, and that depending on which part of it, and this is something I hadn't fully realized, you can have different symptom complexes possibly caused. So this is a hypothesis in neuroscience quite recently, but suggesting that quite a lot of the symptoms of long COVID could actually be related to brainstem dysfunction. We know that there's, in terms of actually what can we do, well, there's individual risk management of various types, the various obvious ones around personal hygiene, hand washing, and so on, and also trying to either distance or keep ourselves separated as much as possible. But also I've put in here, there are various other things like microbiomes, diet, nutrition, and so on, which again are very important. A very quick reminder that Rick's been telling us about vitamin D and sunlight destroys viruses quite quickly, so the outside environment is quite important. And this was also shown in terms of air-conditioned buildings, and just simply by opening the windows, they managed to decrease some of the spread of COVID. We also know that the elderly are particularly susceptible, and there's various reasons for that, and I'm not going to go into these in detail. I did have a whole lot more slides in about this, but I don't think for today's presentation it's so important, because really what we're trying to do is say, well, what else can we do? I've talked about the very basic things, and we're going to come on to nutrition later. From the conventional perspective, there's been a lot of experimentation about drug targets. On the left-hand side of this slide is just a schematic idea of the virus and how it affects cells and which stage of that infection you can try and have an effect on. And what they've done through a whole lot of theoretical modeling is try and work out what drugs might be helpful in this process. And they end up with lovely diagrams like this, which are pretty amazing. What drew my attention to this one is hypericin, of course, is St. John's wort. So it's just interesting, amongst all those drugs, there's hypericin as a possible candidate for helping to treat. And so starting from that basic mainstream context, I'm now going to move on to some other things. One of the Larson cartoons, I'm trying to keep myself out of the crosshairs as far as possible. There have been various drugs that have been considered, and some of these remain very contentious. I'll quickly go through some of them. I'm not going to spend too much time on them. One of the ones, obviously, the previous president of the United States made this one popular. And the hydroxychloroquine, is that useful? Well, there have been various trials out there, and some have suggested a definite potential benefit. This one was one that was an RCT that showed a number of positive aspects of outcome. We know that there are potential mechanisms of action in terms of affecting viruses. And this is a systematic review which looked at a number of studies and found that it did seem to alter the course of the disease in terms of hospital effects and admissions. And they made the very bold statement that there are no unbiased studies showing a negative effect of it. Again, this is part of a systematic review, and I won't go into it too much. However, I will say there have been counter arguments put up saying that this actually isn't the case. And I think it takes quite a lot of digging to try and work out what is real and what isn't real in the research that's out there. But certainly, this is one in a reasonably well peer-reviewed journal and suggesting that there is some evidence. Similarly for ivermectin, which has got a very checkered career so far, it's known more as an antiparasitic drug, but there's a suggestion that in high levels, it is, in terms of tissue levels, it can have an antiviral effect against COVID. And they've looked at some of the likely pathways that it might affect. Here you go. I'm not going to go into that in detail, but it's just to say, look, it's been looked at as a potential effect here. Ivermectin, 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 the diamond red ones. And this was a trial looking at the effect of ivermectin on viral load compared to placebo in green turquoise, ivermectin in red, and showing that not all of this is reaches significance, but there is a general trend that it clears viral load more effectively. This is a meta-analysis and suggesting that there is a shorter duration of hospitalization, a reduction in time to recovery. Particular 11 RCTs seem to be helpful for that. However, there was a criticism of this meta-analysis and saying that really, which I'm afraid is the case for most studies, they're not fully peer-reviewed, and often they are an amalgamation of trials with slightly different doses and so forth and methodologies, which makes a meta-analysis quite difficult. This is one of the latest accumulation of trials suggesting there's been 63, and some of these are peer-reviewed and some are RCTs, and suggesting that possibly is a benefit, but there's probably going to be some criticism of that too. This is one in the latest EBM, which is the electronic journal rather, suggesting that a lot of the trials have, again, serious methodological limitations. And this is often leveled against trials. So it's still up in the air, I think. Going on to vaccination briefly, the medical council statement says that although we're allowed to have our own opinion, there's no place for an anti-vaccine message. So bear that in mind. What's the difference between the effectiveness of the vaccine per se and having a wild infection, that is the COVID infection itself? And really what it's showing, there's been various trials, or at least observations, and the infection from the, protection from the infection itself is slightly better than any vaccine so far. What we're running into problems with now is the original vaccines showed pretty good efficacy in terms of preventing serious illness or death against the original strains, but we're now having to deal with the newer strains, which are showing far less effectiveness, unfortunately, although the death rate is still reasonably protected. But depending on which country you're looking at, there are different levels. Israel in particular seems to be having difficulty dealing with the Delta virus in terms of hospitalizations and serious illness in vaccinated people, I'm talking of. In fact, this is their experience. Sorry, here we go. So this is their cases going on. They had the 2 peaks and now they're having another peak. And about 60% of their population are fully vaccinated. However, nearly 60% have had some severe illnesses despite being fully vaccinated. In the UK, it's less in terms of numbers. Just a reminder that there are other viruses around that are endemic normally, so I've just put that in there. But I draw your attention to the lower 2 things. According to one of the main journals, roughly 2.6 million people die in the world each year of respiratory infections. The COVID death rate as of roughly now is 4.3 million deaths over the last 20 months. Now, and again, we can argue about, is the death rate correct in terms of reporting? Is it over or underestimated? I'm putting this in to be contentious. I'm not saying it takes away from the need to do a lot of preventive and other work, but it's comparing pandemics in the past. So from the Black Death, where there was an enormous death toll, I think around 200 million, through to various other plagues, including smallpox, including to the Spanish flu, which roughly 40 to 45 million, and so on to where we are now. So it's just getting a sense of proportion of what's gone on historically. If we start saying now, okay, what else can we do about it other than the obvious things in terms of diet, lifestyle, etc.? The 4 main components of trying to help someone is obviously to prevent, to help them deal with an infection when it happens, and part of that's the inflammatory process, and then to help them in recovery. And the things that we know about from integrated medicine is that these basic things, you need all of these things working well to have a good foundation to deal with any infection. And so these aren't new ideas, but I put them there for completion. We should think about them, everything from sleep through to good diet, exercise, and the various minerals and vitamins. This is a nice slide put together based on the idea of prevention, infection, inflammation, and recovery, and how the foundational part is important all the way through. And then when you look at other specific parts, there is a good reason to consider different types of support. And in particular, we're looking more from a natural perspective now, what things can we do? And again, depending on whether you're talking about prevention or treatment of the various components, different options are there. I'm not saying all of these are proven. These are just ideas mostly taken from how we deal with other types of infection. But it gives you an idea, if you're interested in certain nutrients and herbs, the kind of doses that have been suggested in this particular article. I'm going to move on here to another controversial one. This is the Math Plus protocol. It's put out by a group or several groups, in fact, of intensive care doctors in the States. And they call it the math because it's what they've been using in intensive care. And they've sort of set the tone from that in terms of things to use. And I'm going to go over their protocol and look at a few of the things that have a degree of evidence for them, not perfect at all. And I won't mention steroids because that's more of an in-house hospital ICU process. But vitamin C, that's their protocol along with the thiamine and heparin. Again, more for in-hospital use. But this is part of their own way of looking at how to treat using the different stages of what the virus is doing and what the immune system is managing. Again, I won't spend time on that. So gladly, Rick has already spent some time talking about vitamin D and its effect with respiratory infections. There are about a number of trials, and I'm not going to spend too long again on this because of what he's already been through. But we know there are protective effects from preventing vitamin D deficiency. This is another one where it's been looked at predicting poor outcomes and showing that those with low levels did statistically worse than those with better levels. Vitamin C, we know in general terms that oral vitamin C may have some effect on reducing respiratory infections. There is some controversy there, but in general, it seems that way. But intravenous vitamin C has been shown to reduce mortality in ICUs. There's a lot of different studies on that, and I think that's fairly well proven. There's various, that's just a nice diagram showing how its effects are thought to be useful. This is one of those trials, and so looking at ICU patients, and they found here that again, if they started early enough, so this is going into ICU, if they started early enough with the vitamin C, their mortality rate was dramatically different. And they only did a certain amount of treatment, that's this first part, before they stopped treating. So it was just the initial 96 hours. But even just doing that, they had a dramatic difference in their mortality. And they've gone on to look at taking it for longer to get a better effect. That's just the rest of that. And they call it a dramatic reduction. And indeed, this is several studies looking at vitamin C in sepsis and very much in favor of vitamin C. They didn't find any against it. Similar stuff, I'm not going to go into these too much, but there's a very good site here if you're interested through Otago University where they go into all of these studies and list them all. Similar one, this is in high dose vitamin C looking at SARS and COVID. And again, they've shown that the mortality in that group decreased. So once again, using high dose intravenous vitamin C. This is from China. Another one, which is actually a retrospective cohort, so not quite the same, but again, showing a tendency towards much better survival. There's been a lot of talk about, well, why don't we know about it? It looks like a lot is being done, but not necessarily reported. This is Paul Marek, who's the author of that math, or one author of the math protocol. Moving on, some other possibilities. Zinc. We know that low zinc seems to be associated with a higher risk of dying from COVID. And this is a study they did looking at the levels in patients and following them up to see what happened. And they also showed it related to the inflammatory protein interleukin-6. This is a meta-analysis where they looked at 118 studies, and again, showing much the same thing. It reduces the risk, duration, and severity of COVID. So reasonably good proof. And if we look at the actual likely possible mechanisms, again, these are theoretical of how zinc works and could work for COVID. These are some of those mechanisms. So not only it has a reasonable way that it might have an effect. Again, we're looking here at a combination of one or both. This one didn't show the effects, so I thought I should put it in. It's an RCT of 214 patients, and it didn't show any obvious effect in doing this. These were oral doses. And I'm not quite sure why, but that's just, it needs to be reported that that one didn't particularly work. They didn't check zinc levels or anything like that before and after. Omega-3 fatty acids may be helpful. There's been a few studies looking at that. This is a critically ill patients with COVID, and it looks like there is a tendency towards a higher survival and less of the downside in terms of kidney function, etc., in those treated compared to the control. Melatonin. This is interesting. Certainly at an experimental level, it's known to help decrease inflammation. And so it may have effects against COVID, but this is very much a laboratory study. And they're just showing here the likely mechanisms because these are better understood between the macrophage white cells, whether they're healthy or not, and how melatonin may be helpful. It's funny enough, well, not funny, it's interestingly enough being used in a small trial in Ebola, and they found it to be to have a positive effect there. Quercetin, another herbal product. We know it has antiviral properties. It certainly has, at an experimental level, some usefulness, and it may actually help vitamin C work better as well. These are some of the RCTs at the moment using quercetin and showing a tendency towards improvement in efficacy. This is efficacy studies. Same with curcumin, showing some potential improvements with those. These aren't large studies though. These are small numbers. Artemisinin has already been mentioned. It certainly has the potential for antimicrobial effects, including antiviral, and there is some evidence that it may be useful there. So just moving on, getting to the point of what can we do about actually affecting pandemics generally. There is a group here in the States that's working on this, and they're called the Pandemic Event Protection Network. And they're looking into the future of how can we actually better disseminate information and get a much more effective overall process happening than the rather ad hoc one that we've had so far. So in summary, I'm suggesting a healthy lifestyle, number one, in terms of diet, microbiome, etc. Certain nutrients, which it looks like it would be very reasonable to try and maximize them. And there are some experimental medications. I've only mentioned a few of them. There are many more that have been looked at and several in the pipeline. I'll mention this is the MASK group, the FLCCC, and that's their particular dose regimen if you are asking what doses to use. They do use ivermectin, and again, this is controversial. They have different protocols for prevention and treatment. Thank you very much.